am really looking, I'm really looking forward to the discussion as well, so that we can address many of the questions related to some of the ideas and concepts that I will share, and how in particular they affect various communities and need to be thought of from those perspectives. So, okay, so the framework with which I'll address my thoughts on getting to the post-pandemic era is laid out in, as well, this piece that my friend and colleague Mark Lipsich and I published about a month ago in Stat News. And the thinking here is really that our response is just in the first phases. We're just, as we describe here using this analogy, just getting into a life raft, and dry land is far away. The end of the pandemic is if we think of it as a baseball game, we're really in the first inning, and there are a number of innings to go. So how do pandemics end? This one, like all pandemics, have two possible endings. The first is population immunity. This is immunity that can be gained either through infection, and the immunity that's gained after people recover from infection, or from vaccination, where the vaccine confers immune protection. The amount of immunity in a population that you'd need, or the fraction of the population that you would need to be immune for the pandemic to end, is related to a term that has become more and more familiar through the popular press even, and this is the basic reproductive number. It's a reflection of just how transmissible a virus is. So for SARS-CoV-2, if that number is around 3, as we believe it to be, that means that around 2/3 of the population will need to become immune for the pandemic to end. So that just gives you a sense of where we would have to get to for population immunity. The second possibility is elimination of the virus. Now, this is what happened with SARS-CoV-1. So if you go back to the SARS epidemic in 2003, SARS was essentially eliminated through, I think, very aggressive public health measures, and never got to anything near the levels that we're seeing today for SARS-CoV-2. I think elimination is essentially not a possibility now, as we're seeing SARS-CoV-2 spread everywhere. So that really focuses us on population immunity, again, either through infection and recovery or through a vaccine. Okay, so what does that mean? These types of figures have also become quite familiar now. We see this is one that Deborah Birx used in a White House task force presentation, and it gets at the idea of flattening the curve, right? So we are trying to balance a couple of things. We can go through and do nothing and see a curve like this one, where we would achieve population immunity, but there would be a huge cost. And the cost comes in a couple of ways. Both it's the people who are infected and potentially die from COVID-19, and also from the threat to the healthcare infrastructure, right? That we've seen it in Wuhan, in northern Italy, and also New York. Just that when you see such high levels, it's such a burden to the healthcare infrastructure that it could crack, right? And so what we're trying to do is flatten the curve in order to limit the amount of disease that's happening at any one time, so that our healthcare infrastructure can cope with the burden. So when we think about how to get to this level of population immunity, there are basically 3 options. The first is to stop social distancing, the kind of effort that we've undertaken, and now that we're seeing in different places, extended or contracted to varying degrees, and just let this go, right? The second is to continue doing social distancing to flatten the curve, but then again, that raises the question of, for how long do you do it? And then the third is social distancing with all sorts of additional measures to the extent that we can to try to not just flatten the curve, but crush the curve, right? And prevent ongoing transmission of any kind, really try to get down to as little as possible while awaiting a vaccine, which is again what we would need in order to provide sufficient immunity in the population. Okay, so the first, and let me just begin by saying none of these options is good, right? All of these are hard and will incur costs, some of them predictable, some of them I think not predictable. So, but there is no easy way, right? That is just I think a difficult truth about where we are. So we do know for sure that letting it go is a bad option, right? So we've seen this in places where it took a while to actually institute social distancing measures, just how bad things can get. So Wuhan shut the city down when they had around 500 confirmed cases in a population of 10 million, right? So this is a city that's even bigger than New York. And they reached a per capita demand for intensive care unit beds equal to fully occupying the ICUs in the US just for COVID-19, right? So this is, it's an intense need placed on, or intense pressure placed on the healthcare infrastructure, right? And it took about 4 weeks from the shutdown to peak ICU need. And that gives you a sense of both the extent to which the amount of disease had spread through the population, potentially undetected, and how long it takes for people to get sick enough that they require they require hospitalization and then critical care. So that first option seems particularly bad, right? Just letting it go seems like that has the potential to be devastating and be devastating quickly. So if we're doing the second option, that leads to another question: how long will social distancing last, right? This is one that we're all thinking about as, you know, we Zoom from home and wear our masks, as I saw people doing even on the Zoom at home. So how long are we in this? So this is a question that we looked at and published a paper on just recently. So I'll take you through some of the thinking in this paper. One of the first things we're interested in is whether there is seasonality, right? So famously, or perhaps notoriously, infamously, the president speculated that coronavirus would be gone by April, right? And this was in part because of what had happened with SARS back in 2003, although I think that was not so much seasonality as an intense public health effort. But there is a sense with which respiratory viruses are seasonal. They peak in the winter and they seem to nadir in the summer. So we were wondering, is there seasonality or what kind of basis can we use to estimate whether there's seasonality for this coronavirus? So to do this, we looked at surveillance data from the United States from 2 different sources. And we looked at 2 human coronaviruses. These are beta coronaviruses that are the closest circulating neighbors in the human population to SARS-CoV-2. And what you can see here is that, in fact, in keeping with the other types of human respiratory viruses, we really do seem to see seasonality where there are peaks in the winter. And so this gave us at least a way of modeling what we might expect to see with SARS-CoV-2. It's not saying it's necessarily this way, but it's saying if it's going to be like something, potentially would be like those viruses that it's most closely related to. So then we wanted to ask, both in the absence of seasonality and in the presence of seasonality, what would happen if we were to institute social distancing for varying durations and with varying effectiveness? And that's what we're looking at in these plots. So we have a whole bunch of different curves here. The curves in the solid lines reflect what would happen in terms of overall prevalence, the amount of disease, in black in the absence of an intervention, and then in these different colors with interventions that were varyingly successful in reducing transmission, right? So something in red that is modestly successful, in blue, better, and best in green. Relatively the same amount of reduction as was seen in Wuhan with the extent of the lockdown there. And then the dotted lines are basically the demand for ICU beds, again, with the notion that those will be 3 to 4 weeks delayed from what we see with the overall case numbers. In blue, these rectangles are indicators of the duration of the social distancing efforts, right? So we've got 4 weeks, then 8 weeks, 12 weeks, 20 weeks, and indefinite interventions. The extent to which we are successful in reducing cases now, right? So the more successful our social distancing efforts, the more we're actually maintaining a susceptible population. And then when we stop social distancing, we should expect to see those people are still susceptible. And so we will see a second peak, right? So anyone who remains, or the extent to which we maintain a susceptible population, that population will then become infected once we stop social distancing, right? So that's why, that's why we see here, for example, with a 20-week effort in green, most successful, very few cases in this time period. Once we stop, we'll see a peak again, right? So you can see here that these modest success rates, around 40% for 20 weeks, there the second peak is much lower than what it would have been otherwise, right? So it tries to give you a sense, basically, of develop an intuition for how these two things relate. Okay, what happens if, in fact, there is seasonality? So here, seasonality can, in fact, create a bigger problem. So with seasonality, we're suggesting that transmission will go down in the summer, potentially because of climatic factors, right? It doesn't circulate as well in warm temperatures, or it's something to do with the absolute humidity. We know those are factors, well, particularly absolute humidity, that influences influenza transmissibility. So if it's the same thing with SARS-CoV-2, then we will see diminished transmissibility in the summer, but it will pick up again in the fall to winter. And so what we can actually see is peaks that are even bigger in the fall and winter, in that we've basically all of those individuals who haven't been infected because of social distancing, and then because of decreased transmission in the summer, once we get to higher levels of transmission in the fall and winter, we're going to see even bigger peaks, right? So if there is seasonality, we face the possibility of a big resurgence in the fall and winter. Okay, so just to summarize that a little bit, if seasonality is negligible, then all social distancing will help, and long, moderate social distancing is probably best. If seasonality is present, then long, weekly effective social distancing is best, but strongly effective social distancing will actually make things worse by delaying the peak into winter. And that is problematic, both because we'll see more transmission, but also because that then coincides with flu season, right? And flu season, we already know, is it puts strain on our healthcare system, right? So putting these two respiratory diseases together will be even more problematic. I'd also point out there's a pretty important event that's happening in November. And it is worth thinking about what the impact of a pandemic and a peak will be in November, when people are supposed to be voting, right? This, I think, underscores the potential importance of the recent Supreme Court decision for the Wisconsin primary voting. So for those of you who are familiar with this, you already know, but there the Supreme Court basically said this is an election like any other election. People should not be able to, people should go in and vote, and it did not enable even people who were supposed to get their mail-in ballots to do so with counting that would continue for some time. So the idea about potentially requiring pretty extensive mail-in voting for November, I think, is one that bears a lot of attention. Okay, so what is really going on here? We think that there probably will be some seasonality, although that's an intuition, not something that we can say right now based on hard data. We still don't know for sure, but it does raise the possibility that one-time interventions could potentially make things worse. Again, in the absence of other interventions, right? So what we're just modeling here is social distancing. We don't include drugs that may be effective. We don't include a vaccine. We don't include contact tracing and other types of things. So this is really just, again, with this framework. There are other potential interventions that could change this. Okay, so we then wondered if we wanted to not have just one social distancing intervention, but in fact, if we started to see another peak, if we would introduce social distancing again, keeping in mind that our goal here is to try to prevent the healthcare infrastructure from getting overwhelmed, how would we do it? And this led us to start thinking about cycled or intermittent social distancing, where again, you're keying your interventions to try to limit the thresholds within hospitals and critical care facilities, right? So this basically led to a kind of a on-off thermostat kind of model where we're monitoring very carefully the kinds of cases or the numbers of cases, and we'd go on when it looks like we're starting to hit this threshold, and once it starts coming down, we can turn off. And then really, when do we end doing this? Well, we would end when, again, we either get a vaccine or we get to a cumulative number of infections such that there is sufficient population immunity, going back to that notion that I began with, that would lead to the end of the pandemic. And this, doing it this way, again, in the absence of other kinds of interventions, would take a long time, right? We're looking at really going out a couple of years. And we can think about this with seasonality, right? So maybe that gets us there a little bit quicker. And we can think about doubling the ICU capacity. So we already know that hospitals like Mass General, Brigham, everywhere, people have converted their ventilators from operating theaters to be ventilators to help people in critical care. So really, all of these hospitals have done an incredible job in expanding their ICU capacity, right? So that's already happened in many places. Effective drugs, drugs that can prevent people from requiring hospitalization, or if they are hospitalized, prevent them from needing critical care, basically function in the same way. They can reduce demand on critical care, and essentially, mathematically, it's the same. They expand our capacity. And this can get us, this kind of cycling can get us to population immunity faster. Like with more capacity, we have just more breathing space, so to speak, forgive the pun, and we can get there more quickly. So for this section, if no seasonality, we have a slow accumulation of herd immunity. Seasonality is helpful in this scenario. And if we increase our capacity, or if we get new drugs or other types of interventions, we can get there faster yet. To do this, however, we would require very, very good surveillance. We hear all the time about the need for testing. This is one reason why testing would be needed. We need to be able to know where are we on the curve, and if we stop social distancing, what's happening, right? I mean, it seems we're already operating in the dark. People describe this whole response effort as trying to build the plane while flying it. Trying to stop interventions without having good monitoring is basically like trying to land that plane with zero visibility, right? So just to keep that in mind, we really need that kind of testing to inform the strategies that we'd use going forward. And of course, intermittent social distancing, I say something like that, and I can hear the economists I've talked with screaming, right, pulling their hair out, because this kind of threat to the economy is severe, right? Even beyond just the one-time distancing, lockdown after lockdown would be devastating to the economy. So we need to think about how to do it in ways that are as informed and tailored as possible. Now, what about that third option of using some combination of social distancing with contact tracing, isolation, quarantine? Certainly these can be synergistic. So we looked at this as well. Here trying to characterize different types of contact tracing interventions, because I should say contact tracing in and of itself is not the intervention. Once you know who the contacts are, the real intervention is that those contacts are able to self-quarantine or get tested and confirmed either they are cases or not cases, right? So the intervention is once you find the people who are the contacts of cases, then being able to do something to help them block the ongoing transmission, right? So we're able to show here that really with social distancing and contact tracing with then effective interventions, we can accelerate the reduction in transmission. And that can get us to a place where, like Singapore or China or Korea, there aren't really many cases going on, transmission within those countries. They're coming, when they are cases, often from outside, right? We're seeing cases being introduced. But that is also challenging. So let's say we successfully flatten or in fact crush the curve and stand up aggressive case finding, contact tracing, isolation, quarantine. If a substantial fraction of the population remains susceptible, right? And if our guess is that there isn't a ton of undetected transmission, then we're going to be in a situation where we're going to need to continue to restrict travel and intensively screen travelers and everyone until we get a vaccine, right? We'll then be in that position of waiting until we have a vaccine, which I have to say is something we hope for, but isn't a certainty, right? There are many different diseases for which we have yet to develop effective vaccines despite decades of trying. HIV is just one classic example here, right? But we would be in a position of trying to maintain, again, this aggressive surveillance until we get a vaccine, right? So, and just to put that in context, Singapore, with arguably the world's best public health system, trying to follow this path, they started to have outbreaks, particularly in migrant congregant settings, that led to a 4-week lockdown in Singapore, right? So Singapore, even though they tried to do this and they were probably the best equipped to do this, they still had to go back to a lockdown for a month, right? So very hard to do, and itself brings with it many challenges. And this is what I was getting at before. None of these three paths are easy, right? Each have their own challenges. And it's really going to be a question of what we as a community, as a country, decide to do. Okay, so where are we now and how are we doing? So this is data very recently. The New York Times has put out these beautiful figures that really, I think, help summarize data very well, but this gives you a sense. You know, we're seeing now, I think it's near 70,000 deaths, and we're, I think, going to see many, many more, particularly now as some states have decided to try to open up. I think, you know, it's premature, and that gets back to this notion of trying to land a plane with zero visibility. I think that we can expect what might happen in those situations. But I wanted to also talk a little bit, particularly with this group, about why it is we're seeing such disparities across different communities. So part of it is that there's been varying success in social distancing. And I think this kind of concept is probably familiar to all of you. There's some some groups where you can stay at home and some where it's very difficult for a variety of reasons. Also, home structures are different, multi-generational families, many people living within one unit, right? I mean, it's just those kinds of conditions that might promote acquisition and then transmission of COVID-19 could contribute to inequities. And we can see, again, this is data from about a month ago when they last presented this figure, but I think it was quite illustrative, right? That there are some places in the country where we're seeing very, very different choices about how to approach this challenge set before us. And some places very successful, right? So Seattle, which seemed to really crush the curve, they saw distancing to a remarkable extent. Travel fell from an average of 3.8 miles per day per person to 61 feet, right? So that is pretty remarkable, and certainly not something that we can see every place. So this is, again, something that seems to in part rely on ability to stay at home, right? And those who are able to stay at home often have the capacity to do so because of resources, or they can work from home and so on, right? And so we see this as well, that there are just differences in how much populations can distance depending on wealth. I will share one concern that I have that's quite ongoing. That's we have seen since the abdication of the federal government's response and leadership, that strategy has been thrown to the states. All the response has been thrown to the states, and we're seeing local public health jurisdictions and states try to make these decisions, and doing so very differently. So we are seeing this fragmentation where some places are choosing option 1, some places option 2, some places option 3. When we want to restart an economy and consider interstate commerce, right, and consider that none of our economies are really local, we're all totally interconnected. You know, how do you restart building cars in Michigan that require steel from Pennsylvania, that require electronics from California, right? All of these places are totally interconnected. And if we're choosing different paths for how to manage this, how do we come together? I think this is a huge problem. And in fact, this kind of fragmentation I described at a national scale. And then I asked the question here about what happens at a geopolitical scale, thinking about the world at large. But really, you can even think about this within communities. Every business is made up of multiple sectors, right? That there are some, you know, and has supply chains, right? So how you think about connecting all of these different components, I think is again, going to be a huge challenge. So what do we do now? This is a slide I wrote a month ago for a talk I gave. It is the same thing that we need to do still. We need to build capacity to control transmission by continued social distancing, massive testing, and meeting the needs of healthcare workers for personal protective equipment. Those are still our needs. It's kind of shocking that we were in this in the first place, right? But yet a month after writing the slide, it's still the same needs. We need to invest in efforts to mitigate the impact of COVID-19 by finding treatments. There's been some advance there with remdesivir. It's not clear, to me at least, how much of an impact remdesivir itself is going to make, because it's an injection drug. It's not something that people take orally. So it's really only people who are hospitalized who could benefit from remdesivir anyway. We need to continue thinking about how to increase healthcare capacity and further accelerate work on a vaccine. Now, I wanted to just briefly mention some other work we've been doing, because part of this testing now is not just figuring out who has the infection, but who has had the infection. Again, the fiasco with testing from the beginning has meant that we haven't really been able to track what's going on in our communities. And so we need now these serological studies, the seroprevalence studies, to understand who and which communities and to what extent has the disease already gone through. And there are a variety of different challenges, but keeping in mind the time and that I would love to have a conversation with members of this community. What I will just say is this is something we've been working on in a variety of ways. One of them is that we've developed a statistical framework to help with seroprevalence analysis, forecasting, and study design. So we're knowing that many others are going to be trying to do the same kind of thing, to figure out all across the country, pretty much independently to some extent, right? Because again, this fragmentation, we wanted to try to provide tools that enable people to really think about these problems and help them. So we have now a website where we have calculators that people can use. The notion is that we're all standing shoulder to shoulder trying to face this challenge. And we need to be able to provide tools and share knowledge, share experience. And this is just one approach to doing so on these types of studies in particular. And we look at what can be done with different types of convenience and formal sampling protocols so that we can estimate the extent of disease in a population and then think about how knowing those values can then feed into our strategizing about what to do next. Okay, so with that, I'll just acknowledge the various colleagues, and I'm just putting their names here in the context of the citations, but this is work that, again, it really does feel like the community is coming together. This is work done very closely and in great collaboration with a number of people at a number of different institutions. And in case you're interested, these are links to the work itself that you can feel free to peruse. And so with that, I'll stop this talk and open it up for discussion.
Great. Thank you so much. I'm going to kick us off. I'm Becca Lee and work with the Community Engagement Program at Harvard Catalyst. And our community advisory boards have really helped us think about what the priorities for our Q&A today should be. And the top of mind was a focus on health equity. So I thought as the questions were coming in, and I just want to note to everybody, there's 120 people. So I'm going to be madly trying to prioritize, the questions that most people are interested in. But for the first question, we were just wondering, how do you think that the work you presented today addresses health equity?
Yeah, so I think one critical piece to this that we've seen play out is that vulnerable populations are getting hit hardest and first, right? And we've seen that in New York. Where you can see the highest rates. There was recently a letter in JAMA that showed that there were variations by borough, right, and their association in hospitalizations and mortality by borough. And we see that in the Boston area too, with the high rates in Chelsea and very low rates in other communities, right? So I think that while the models that I'm showing are just generally for populations, what we're really seeing now is how is this playing out? There are some communities, again, that have successfully distanced, right, that are able to engage in social distancing, and some that haven't been able to, and some communities in which transmission has been moving very quickly. And I think this gets to additional challenges going forward, right? So if this is the first wave, what happens? Which communities are at risk next? How will the differential experience of this first wave play out? Even thinking ahead. So I think that there are equity questions at many levels. As we continue also thinking about introducing interventions like contact tracing, how does that play out, right? So I mentioned before that contact tracing, so identifying cases and then tracing the contacts of those cases with the notion of then trying to block ongoing transmission. The identification of the cases is itself not the intervention. The intervention to stop transmission is really getting those contacts to not contact other people, right? So to try to quarantine and isolate. And that has, I think, two challenges. One of them, what supports are we offering to help people self-quarantine, right? So this again gets to an equity issue. for some communities, quarantine, again, is no problem. That's why they've been able to effectively engage in social distancing. But for others, right, if they have to work in order to feed their family, right, they're not going to be able to engage in quarantine even if they were a contact, right? So how are we going to help people actually quarantine or isolate, right? What measures are there? So I think that there's an inherent inequity there too. And then, there are questions about stigma and privacy, as there are with all health conditions, especially ones where we're seeing different communities differentially affected. Right? So I think there's another big equity issue there. As we start thinking about, and has been in the news a lot, digital contact tracing. So using smartphones to help with contact tracing. How does that play out? So the notion with using cell phones is that it seems like with COVID-19, we know that you can actually transmit the virus 2 days or so before you even start to show symptoms. Right? So what you'd need to be able to do if you were doing manual contact tracing is once those symptoms start, try to think back, who were all of the different people you'd interacted with over the past few days, right? That's hard to do often, right? So we have the fallibility of human memory. Cell phones can keep track of who you've been close to using Bluetooth or GPS technology or so on. And so there's a theoretical advantage to being able to use digital contact tracing to both identify prior contacts and also then alert them just through their phones, right? They can keep track of who you've been in contact with, and if someone gets targeted or gets flagged as having been a case, then all of their contacts will then get some kind of alert. But again, we have the challenge there as well. Now, and I think that has two challenges. Who has cell phones, right? So there's some issue about who has cell phones, and then what's the privacy around those kinds of interventions, right? There are vulnerable communities that, where trust in government is low, quite reasonably, right? So will people even engage? And could the fact that some communities engage and other ones don't, what will happen? Again, that could exacerbate inequities even further. Mm-hmm. So there are, I think, equity questions on many fronts here.
Great. Thank you so much for kind of that overview. I have one question in the chat from Sarah that I think is a good follow-up. And then I do want to give a nod to all the people who are interested in kind of summer to fall stuff that we'll go to next. But Sarah had this question about how do you take into account the health impacts of a closed economy, things like hunger, limited access to non-COVID related healthcare, small hospitals that are struggling financially. Do you have any thoughts around that? So that one seems pretty tricky, but very closely related to health equity.
Yeah, I think that is a critical question too. I am not an economist, so it is hard for me to be able to say what would be the impact of those types of interventions, but totally acknowledge that there are costs to whatever we do. What does seem pretty clear is that if we don't engage in social distancing, we will see the challenge to and perhaps collapse of our healthcare infrastructure anyway, right? I mean, that seems like we've seen that, right? We can see what the threat has been. And not only is it in taking care of COVID-19 patients, right? But if they're totally overwhelming hospitals, then everyone else, right, who has a heart attack, a stroke, appendicitis, whatever it is, won't be able to get in, and we'll see massive excess death because our healthcare infrastructure is overwhelmed by COVID-19, right? So there are huge costs to not trying to contain this. And those costs will have ramifications throughout the economy as well. No one will want to go out, even if the economy is supposedly open. Who would want to go out in those kinds of circumstances? So I think that, of course, that is, both avenues are tough to predict, and again, it's not easy either way. There are challenges, there are potential costs in both, and how you weigh them, I think is really, really tough to say.
Great, thank you. So I am going to go up to the top. While you were talking, there's a lot of chatter about seasonality and social distancing from Alicia and Ronnie and Laura. And Alicia had this question around: is there a possibility that folks can carry the virus from the summer into the fall? And Laura was wondering about loosening social distancing in the summer and then reinstating more in the fall and winter. Do you have any more to say around that issue about, what's happening with this kind of seasonality opening and closing?
Yeah, so there are a few issues there. So one, to the biological question of for how long do people carry the virus, right? So it seems like the infection and viral shedding takes that it's a couple of weeks around there. Right, so I don't think that individuals would themselves continue to be infectious for months, right? The population, I think we'll see transmission of the virus among individuals within the population over months. I think we're going to see it continue to spread globally, right? But I don't think it's that individuals would carry it for that duration. Is there seasonality? It's a question we still don't really have an answer to, but I want to underscore that seasonality isn't, a binary. It's not a 1 or a 0. It's not that there is transmission and then in summer there is no transmission, right? It's that transmission will go down a little bit, but it doesn't drop to 0, right? It's just going to decline a little bit. And then we expect in the summer or in the fall and winter, again, if it behaves like the other respiratory viruses, that it will pick up again and become more transmissible, right? Some of that may have to do with how people interact, right? Are they closed? This is what we also wonder about with influenza, because there's definitely a component of the role of schools for influenza transmission, where you have lots of kids crowded in the same place. That definitely helps promote transmission for flu, and perhaps it would for other respiratory viruses like SARS-CoV-2 as well. So just to clarify, with seasonality, we would expect it to go down, but not to 0, right? It doesn't flip a switch. It just kind of decreases a little bit and then comes back up. We still don't know for sure whether that happens, but it seems to me a likelihood, a reasonable likelihood. So what that would do is, again, lead to more spread in the fall and winter.
And so to follow up on that, would you encourage large crowd activities this summer?
I would not, right? So I think we still don't really know which of the social distancing interventions are most effective in limiting transmission. This is a topic of active research where people are now using mobility data from cell phones and other sources to understand, when varying social distancing interventions were introduced, how successful were they in limiting people's activity, and then following that in reducing hospitalizations and deaths, right? Because that's really the measure that we're interested in. And it may be that we don't need to have this full lockdown, right? We may be able to have tailored interventions, like just school closures or particular kinds of workplaces or something like that, where we can say reducing restaurants and cafes to 25% capacity or 40% capacity would help reduce transmission overall in a way that's sufficient, right, for whatever your goal happens to be. And again, that goal is critical, right? So strategy, are you trying to flatten the curve, right, or crush it and prevent all transmission, will inform what types of interventions you'll choose. And then a combination of interventions may be successful. So some tailored social distancing plus case identification, contact tracing, quarantine, and isolation may together be sufficient so that people can go back outside, interact with one another, so long as we have these other interventions in play, right? So we're really still putting together our toolkit and trying to figure out which ones go best together to enable opening up of the economy and for people to emerge from this blunt instrument of total lockdown.
Great. That last point you were making actually is pretty well connected to Franny's comment here. So I wanted to jump on this one. Saying, you know, say there's a lack of leadership on maintaining social distancing over the summer. Does it make a difference if we as individuals continue doing it? Does it make any difference if everybody else in our neighborhood is not socially distancing and we stay home?
Yeah, it makes an individual difference, right? I mean, your own individual risk would be lower. So it depends as well on what your, it depends on how you want to approach the problem, right? So by removing yourself from the possibility of, or reducing your risk by staying at home, you might protect yourself while, you know, if people are starting to now emerge, right, and start interacting, you might see transmission in those populations, and that could heighten your own risk if you do go out, right? So it is absolutely the case that there is a community component to this, but there are also individual choices depending on your own individual risk.
Great, that's helpful. That's helpful. So we've been seeing a lot of limited PPE availability, and we were wondering, is there a way that we can estimate the contribution of limited PPE on the transmission rate we have seen in our healthcare community? Any thoughts on that?
Yeah, so I haven't seen direct estimates that relate kind of amounts of PPE, but it is absolutely the case that we're seeing infections in our healthcare workers, right? I mean, we've seen this in, you know, there were numbers reported from the Boston Globe. I haven't seen them recently, but you know, a few weeks ago, they were keeping a tally of how many healthcare workers at Boston Medical Center and UMass Memorial, all of these places, what is, you know, how many different healthcare workers are actually getting infected, right? And some of that is community transmission, and some of that is transmission in the hospital, right? Because of a lack of PPE. And I know, you know, hospitals have come up with ways to take their N95s and disinfect them, right? To use hydrogen peroxide or UV or other measures to take these masks that, you know, I remember being disposable. You'd wear them one time, you'd throw them away. And now they are so valuable that there are these whole protocols for sterilizing masks so that they can be reintroduced for use. I mean, it's so absolutely the limit of PPE availability has contributed for sure to putting healthcare workers at risk. I can't speak to the exact numbers, but it seems to be a question that that's one route of transmission.
Great, great. So I'm looking, we have about 10 minutes left and lots of questions. So maybe we'll try to take about 2 or 3 more. And Pat is really interested in the long-term care facilities that have been hit so hard, and had a question about, do you think it's possible to prevent a second wave from impacting this population even more?
Yeah, so I think, you know, again, so first, yes, that we have seen just these long-term care facilities, retirement communities just devastated by COVID-19, right? These are the high-risk populations, right? The people over the age of 65, where the mortality rates, as we've seen all around the world and here as well, they're just shockingly high, right? So what can we do to help protect those communities? Well, you know, when we start having testing, right, being able to identify individuals who are at risk, so you can limit, really, the way to protect them is to prevent people who are infected from going in, right? And once it gets in, it will spread around, right? So by trying to employ testing and other types of interventions to help limit the opportunity for entry of the virus into these communities has got to be key, right? So, and there are a variety of different ways we can imagine on how to do this, whether it's routine testing of everyone who works there, whether it's trying to limit, again, visitors, making people who work there actually stay, right? So we're creating some kind of dormitory situation such that they're not going back to communities where they're seeing transmission and then potentially introducing it, inadvertently introducing it, again, because there are some people who could be asymptomatically infected. They might not even know. Right? So some combination of these types of interventions may be needed to help prevent transmission in those highly at-risk congregate settings.
Great, thanks. So I think I have one really, well, actually, I think I can fit two more in. So there was also a question here that was connected to that about ways to protect other folks, like immune compromised folks or elderly folks that might be living alone and having maybe schools open back up, but protecting those who are more immune compromised. Do you have any other thoughts when we're not talking about kind of a residential situation, but immune compromised folks in the community, what we can be doing to protect those people?
Yeah, and this is another, I think, point to just how much we as a society have to really band together and support those who are in need, right? So identifying those at highest risk and being able to provide them with the support they need, because it is absolutely going to be the case that those at high risk, when there's still an epidemic going on, will need that kind of support, right? If they're not able to go out and do their shopping, or if they can't visit with people because of risk. I think, again, testing, trying to identify what is safe, what is not safe, and providing them with the food and the other things that they need for daily living, right? I think those are going to be the tasks incumbent upon us as community, as societies, where we care for each other, right? Figure out what it is that we can do to help support those people who won't be able to, even when we start to lift social distancing, really get out because of risk of kind of resurgence of the virus. And that also, again, points to testing, right? We need to be able to monitor what's going on in our populations carefully. So it may be that in some places like Seattle, they've crushed the curve. There's very little transmission. People who are at high risk could feel more comfortable going out, as long as they know there's really no transmission or very, very little transmission going on in their communities. But once, if we have careful testing at high level, they start to see a rise, it may be an indication to them, okay, it's time, because I'm at risk, to stay back at home, right? And then that the community could have some kind of supports to help enable those at risk to do so.
Sure, great, thank you. So I have one final question, and that's I think a good summary, and you can kind of take this wherever you like. So if you were in charge, based on what we know, what recommendations would you have put in place in the short term? What would you do right now if you were in charge?
Yeah, so the key thing right now is to figure out where are we on the curve and how many curves are there, right? So I mean, we need, again, both testing for who's infected, and we need testing to understand who has been infected, right? So, and different communities will have different curves, right? We've seen this, again, Chelsea has had a curve more like that, and some communities, in Cambridge and Newton, where we've seen very little activity so far, right? So what communities will remain at risk because they have large fraction of susceptible individuals, which ones are at lower risk for recurrent waves? How do we support each of those communities? We need to know where each of those communities lies on its own curve. I mean, I think a lesson from this is just how hyper-local epidemic spread is. So I think that the first thing that we really need to get up and running is this kind of testing, so we can develop an informed strategy that, again, doesn't use these blunt instruments like keeping all of the community at home, but can use more informed, tailored, softer touch kinds of interventions that might also enable our economy to get up and going and limit the devastation from the recession or depression that we're going to enter into, right? So how do we actually get people back to working, right? And knowing that is, again, a critical thing that we're going to have to balance here. So that I think is really the first step. And then the second is invest in all of those efforts to develop new drugs and test them and develop new vaccines, because those can accelerate our off-ramp here. Right? This is something we're going to be dealing with for a long time. But as soon as we can really expand our toolkit and have those types of interventions, it can accelerate our movement towards that dry land that I began with, right? It can get us towards much more quickly towards that end of the pandemic. I think you're still muted, Becca. Yeah.
Thank you so much. This has been really fantastic, and I thank everybody for adding your questions to the chat box. We didn't get to all of them, but I will save them so I know what the most pressing issues are for folks. It was just so nice of you to take your time out of your very busy schedule doing all this work to join us. So thank you so much. I'm just going to flash up here the next one in our series, just so everybody can know that there's more to come. Let me just move this here. So up next on May 14th, there's going to be a session called Building a Research Infrastructure for Equity in COVID Treatment. So right along the lines of what we were just hearing, treatment is where we need to be investing next. And this is going to be hosted by the Boston University CTSA. So again, this is a program that we're putting on between all 4 CTSAs in Massachusetts. And we really just thank so many people coming out, being part of the conversation today, and for our wonderful guests. So I think with that, if you have any questions or action items related to what you heard today, you can feel free to email me. This is my contact here. And Karen, do you have any final words you'd like to add?
Someone is asking about the availability of the recording, and I think we will make that available. Is that right, Becca?
We will, yes. Anybody who pre-registered will get an email within the next couple of days, and we'll make sure it's linked there.
Great. And lastly, Anton, thank you so much. That was just fabulous. The comments thanking you are profuse, and everybody really appreciates it. It was just really valuable. Thank you so much.
Well, thank you for the opportunity.
Thank you.
Great. Thank you so much.
Bye-bye.
Bye-bye.